Hello, and welcome to our session. I'm Dr. Thomas Bauer, Chair of Surgery of Jersey Shore University Medical Center, and I'm proud to offer today's program with my esteemed colleagues, Dr. Elkwood and Dr. Kaufman, on breaking borders, providing world-class treatment for peripheral nerve disorders. Next slide. The objectives of this session are several-fold. We will ensure following this that you will understand our commitment to our international programs. You will understand the goals and achievements of our Center for Paralysis and Reconstructive Nerve Surgery, including the many surgical innovations and the scopes of conditions that we treat with our research endeavors. Our attendees will be able to describe brachial plexus injuries and explain the outcomes in treatment using peripheral nerve surgery. And our attendees will be able to discuss surgical treatments available for managing diaphragmatic paralysis and the many benefits of this. Next. Jersey Shore University Medical Center is a 620-bed hospital, part of a very integrated Meridian Health network spanning a large area of New Jersey, and it is the largest healthcare system in New Jersey. We have over 7,000 physicians, approximately 20 hospitals. We have over 440 different centers across the state providing various forms of care with the entire continuum of care. And it's this process that has enabled us to build a internationally known program with our center. Next. One of the many benefits of our system, and we are centered at Jersey Shore in the middle of all of these sites, is that we are within approximately an hour of the 3 New York airports, less than an hour to Newark, New Jersey's airport, and just over an hour from Philadelphia, with a private airport 5 minutes from the hospital. And so this allows easy entry to our facility from across the country and across the world. Next. We have many partnerships. We have our medical school and have received many awards at Jersey Shore with industry, state and national and international entities. Next. So as I stated, Jersey Shore University Medical Center is an academic hub where our Center for the Management of Peripheral Nerve Disorders is centered. We have over 1,500 medical and dental staff members, over 4,000 team members. We're a local trauma center and pediatric trauma center. We lead cardiac surgery in the area and many other significant components which make Jersey Shore an excellent academic facility to house our center. Next. The Department of Surgery, which I am honored to lead, has received a Joint Commission designation for several centers. We're one of only a few for the management of lung, esophageal, and hepatobiliary cancer. These designations ensure that we have the ability to provide minimally invasive care that follows protocols, has been evaluated, and is seen to be centers of excellence. And it's that experience that enables us to lead many other centers, such as the Center for the Management of Peripheral Nerve Tumors and Paralysis. A significant component to this is our commitment to multidisciplinary management, and Drs. Elkwood and Kaufman will expand on this and how it relates to our center that we're discussing today. As well, we're a leader in clinical research that we will show you as part of this center, but it spans many other components to our Department of Surgery. Next slide, please. A common topic that's come up obviously recently is how do we manage surgery during COVID. We have universal testing of our patients and allow for them to be separated and kept healthy preoperatively and postoperatively. We have university masking protocol with all of the personal protective equipment we need for our staff and our patients. We were one of the early hospitals to receive a large volume of COVID patients, and so we have an extensive experience in managing COVID and keeping our non-COVID patients safe and separate as they go through their experience. And we've really expanded our ability to provide for the needs of our patients and our families who are traveling or are simply local and getting their care here. Next slide, please. Our Center for Paralysis and Reconstructive Neurosurgery was founded in 2010 as the first of its kind as an innovation center to provide world-class advanced surgical treatments for paralysis and nerve injuries. We have a multidisciplinary group of board-certified surgeons and other specialists that are centered on restoring functioning and improving the quality of life of our patients. We have a dedicated service here for domestic and international patients that help coordinate their care and the needs of the family. From a research standpoint, we have over 25 IRB approved studies related to this. We have numerous international and national presentations and over 100 publications in the form of articles, chapters, and textbooks. Next. The Center for Paralysis and Reconstructive Surgeries philosophy is that we're centered on compassionate patient care. We are committed to surgical precision and expertise. We are super specialized in surgical innovation and round this all off with our clinical research to continue to improve our quality and continue to make our outcomes better. Next slide. This represents a portion of our team, but is by no means completely inclusive. Our plastic and reconstructive surgery group employs approximately 200 individuals throughout the multi-state area, and this is a sample of the leaders related to our center. As well, the hospital supports our center with many other individuals from a multidisciplinary care. Next slide, please. Our volume has continued to grow over its inception, and there's many other patients that come to us that are not officially part of this center, that are not counted in these numbers, but because of our experience here, when they have other needs, will find themselves coming to our hospital. So the entire impact of our center is only a fraction of this in this slide. Next slide, please. In terms of our domestic and international breakdown, you can see that it continues to improve. And early on was a nationally known program and continues to increase in our international patients since our initiative began in 2015 from countries all across the globe. Next slide, please. As I mentioned earlier, our research achievements are numerous in terms of our active studies, which ensure that there's scrutiny over the inclusion of our patients and that we're following our various protocols. We continue to develop new procedures and apply the same academic rigor to them. We have international and national presentations across many of the societies that deal with paralysis, pulmonary disease, or nerve reconstruction. And as mentioned, 47 peer-reviewed articles, 15 book chapters, and 5 up-to-date sections to ensure that not only are we providing excellent care to our patients, but we are doing our best to educate the medical community in these efforts. Next slide, please. A recent textbook led by Dr. Elkwood and Kaufman on rehabilitative surgery And there's several chapters in this on our experience that I am honored to be part of, and very proud of Dr. Elkwood and Kaufman's leadership on this important textbook. Next slide, please. So our center has many key components, some here. So we do telemedicine evaluation of and patient selection to facilitate the process for our patients and minimize unnecessary travel. Once it's deemed necessary for them to come here, then we work on coordinating their travel and their local accommodations. We have an expertise that spans the globe in terms of working with health insurances. We have on-site patient and family concierge care as part of the center, and a significant component within the hospital itself. Our surgical precision and unparalleled outcomes will be made evident to you as Dr. Elkwood and Kaufman present their care. And then we continue our follow-up care and communication with our patients for many years after their care. Next slide. So the Center for Paralysis and Reconstructive Surgery was founded and is co-directed by Dr. Andrew Elkwood. He's an assistant professor of plastic and reconstructive surgery at our Hackensack Meridian Health School of Medicine. He's an international expert in brachial plexus reconstruction. He's a super specialist in pelvic pain syndromes, pudendal neuralgias, and piriformis syndrome. And he has numerous peer-reviewed articles, chapters, and textbooks. Next. Dr. Matt Kaufman is the co-director of the center. He's an assistant professor of plastic and reconstructive surgery at our Hackensack Meridian Health School of Medicine. He's a voluntary clinical assistant professor of surgery at UCLA Medical Center. He's a pioneer and international expert in phrenic nerve reconstruction and diaphragmatic paralysis. He, as well, is a super specialist in nerve reconstruction for headache conditions, occipital neuralgia, and post-traumatic headaches. And he, as well, has authored numerous peer-reviewed articles, chapters, and textbooks. It is an honor to work with these super specialists as we care for our patients. Next slide, please.
Thank you, Tom. So as we mentioned previously, the philosophy of our center, one being innovation, and innovation can be challenging due to skeptics, and when done properly and done with a research base, can be very effective at advancing technologies and advancing care for conditions that have previously been untreated or undertreated. And that's a big part of our goal, is to care for patients with conditions that have historically been untreated or undertreated. Next slide, please. A second component of our philosophy is super specialization. When one really focuses or hyper-focuses on certain conditions and treatments and techniques, they can become an expert, they can become a pioneer and someone who can be internationally known for skill set and for outcomes. And so in our practice, in addition to performing the general realm of plastic and reconstructive surgery, we focus attention on one or more of these so-called super specialties, particularly in the realm of peripheral nerve disorders and associated paralysis sequelae. And so by combining super specialization with innovation, we've been able to provide world-class care for some of these conditions. Next slide. So we break our treatment categories down into several components. The primary one being peripheral nerve disorders, and I'll explain on the next slide about that. But these are conditions outside of the spinal cord that affect function in the arms, the legs, the facial area, all parts of the body, basically from head to toe. The second category would be manifestations of spinal cord injury. And we know at this point in time in history, there's no cure for spinal cord injury. However, we can sometimes deal with some of the specific components of spinal cord injury to improve quality of life or even restore some aspects of function. The third category would be post-stroke sequelae. And again, a stroke is a central nervous system disorder that has peripheral components and several components that can affect function, that can affect quality of life. And even though through our surgery we can't overcome the underlying mechanism of the stroke, we can deal with some of the peripheral aspects or peripheral complications that occur. And finally, disease-specific disorders. These are typically non-nerve related issues that are also within the larger category of undertreated or untreated conditions where reconstructive surgery can play a role and provide treatment when previously there has been no treatment. Next slide. So peripheral nerve disorders from head to toe range from headache conditions that cause pain, facial paralysis, such as with Bell's palsy or post-stroke, vocal cord paralysis due to surgery or tumors or other conditions, and a whole list of other things. Some of these are conditions which we are the only center in the world that's treating them. For example, diaphragm paralysis, pelvic pain is treated very scarcely throughout the world. Erectile dysfunction, we've developed a procedure that we're able to go back in a chronic situation and restore erectile function, and other conditions where treatment may not be available anywhere in the world or in very limited capacity throughout the world. And we have really hyper-focused and super specialized in some of these areas. Next slide. Spinal cord injury, as mentioned, is not something we can cure. However, some of the components, such as ventilator dependency, restoring sensation to pressure-prone areas to prevent pressure sores, certain aspects of arm and hand paralysis, and even bladder control to try to improve function and improve quality of life for patients living with spinal cord injury. Next slide. Post-stroke, same thing. We can deal with certain aspects of the stroke, the facial paralysis, the arm paralysis, in some cases the swallowing difficulties, and the vocal weakness using these peripheral nerve surgery techniques. Next slide. Under the category of disease-specific disorders, I'll mention a couple. It's not an exhaustive list, but just some of the more common things we see. But Graves' disease is a thyroid disorder, and approximately half of the patients with Graves' disease, representing roughly 5 million people in the US alone, have an eye condition or Graves' ophthalmopathy that you may have seen or be aware of this a condition where the eyes are bulging from the head and causing other issues related to vision and appearance. And next slide. And we have a treatment center here, one of our doctors who's a specialist. Next slide, please. Who can reverse this condition. This is a treatment that's done in a few select centers throughout the country, throughout the world. And in our center, we have a doctor who's probably amongst the most experienced in reversing this condition. You can see before surgery above, and then after orbital decompression surgery to reverse this aspect of the Graves' condition. Next slide. Another condition which is untreated or undertreated in many parts of the country and many parts of the world would be lymphedema, a condition which is estimated to impact about 10 million people in the United States alone. It can affect limbs, it can affect other areas of the body, primarily the limbs, and you can see here what happens in the leg when the lymph nodes are disrupted, where the leg has extreme swelling. Usually it's one side of the body or one limb as opposed to the other, creating pain, dysfunction, and typically in the past has been untreated or undertreated. Next slide, please. And one of our physicians has a skill set in the various treatments available for lymphedema and has advanced some of these treatments These are treatments that are available in a few select centers throughout the U.S. and throughout the world, and we have amongst the most experience in performing these treatments to reverse this condition, to restore form and function to the limbs that are impacted, and reversing the pain and dysfunction that can occur. Next slide, please.
The surgery was, as I mentioned, was relatively easy for me. I had it in October. I was back on the golf course in March. My arm is smaller because I've been going to the lymphedema clinic periodically and they take measurements. I'm wearing a size smaller compression sleeve. I have a blouse that I could never button. It's a 3/4 length sleeve, button the cuff, and I can now button the cuff. I'm really happy and excited about that.
So that other conditions within the realm of disease-specific disorders would include cancer reconstruction, such as head and neck, breast, skin, and soft tissue, where we work with our oncologic surgeons, or in some cases, the patients are referred to our center for this treatment. We have conditions that impact the abdomen or the abdominal wall, such as complex hernia and sports hernia. You can see the diagram to the right where patients that have the most complex forms of hernia with loss of soft tissue in the abdomen, we're able to reconstruct using methods that were developed in our center and pioneered in our center. We deal with some pediatric issues related to vascular malformations such as hemangioma, and in some cases issues that are not treated in other centers because of the severity. And finally, conditions related to degenerative bone loss from such things as radiation or steroid use, where we're performing advanced reconstructive methods to transfer bone to areas where there's been bone loss to restore form and function. Next slide, please. So with the remainder of the talk, we'll focus on our two flagship programs. These are the programs that attract patients from around the U.S. and from around the globe. They've been our busiest programs in our center, and we've spent years, developing and perfecting these treatments with outcomes that have been published in numerous articles and chapters. We'll talk about phrenic nerve reconstruction for respiratory muscle paralysis or diaphragm paralysis, and then brachial plexus reconstruction for arm paralysis. Next slide, please. So the diaphragm is the breathing muscle, or the muscle of inspiration. When we breathe in, the diaphragm pushes everything lower in our abdomen, allowing the lungs to expand. It's an important muscle. It's a muscle that's not focused on or thought of very often, but when it's dysfunctional, it creates a lot of morbidity and a lot of problems for the individual. Next slide. You can see on this X-ray, on the X-ray on the left, where the diaphragms, which are sitting below the lungs, are in their normal low position, and when the diaphragm is paralyzed, the X-ray on the right, you can see that the diaphragm is elevated on the right side, the side opposite the heart. Next slide. The phrenic nerve is a nerve that comes out of the spine at the cervical level, and it's the impulse or the supply to the diaphragm muscle. And so when that nerve is injured, the diaphragm becomes paralyzed. It's no longer functioning, and breathing in becomes impacted. So it's harder to take a deep breath in. It's harder to exert yourself. It's harder to exercise. It's even harder to sleep. And the nerve can be injured anywhere along the pathway. Next slide, please. The causes are multiple and varied. It's ordinarily from some kind of acute or chronic trauma. It can be inadvertently injured during surgery in the neck or chest. We also see patients that have cervical spinal cord injury, several thousand a year. And overall, there are many thousands of new cases in the year per year in the U.S. alone. There are probably many thousands of people out there in the U.S. and the world living with this condition. The result is shortness of breath, which can be anywhere from moderate to severe, or in the case of spinal cord injury, can result in that individual being on a ventilator. It also leads to susceptibility to other breathing problems, especially sleep apnea and sleep disorders. And in many cases, or some more severe cases, the patient can be oxygen dependent or even ventilator dependent. Next slide. You can see the effect. So sleep disorder, the patient often requires some kind of breathing mask, bending over. The patient feels short of breath and exerting yourself or any type of exercise. Next slide, please. The long-term consequences would be exercise intolerance, sleep disturbances. Because it's hard to exercise, the patient gains weight, which makes the symptoms even more severe. There's a significant impact on quality of life, and then a susceptibility to respiratory disorders, such as pneumonia, COPD, even mental illness as a result of a change in quality of life and sexual dysfunction. In this day and age, also a susceptibility to more severe COVID if the patient were to get it. Next slide, please. So we pioneered this treatment, which is a surgical treatment to reverse diaphragm paralysis called phrenic nerve reconstruction. It was initiated in 2007. And to date, we've published 8 or 9 peer-reviewed articles in multiple chapters, greater than 85% success based upon long-term follow-up in hundreds of patients. We have the largest worldwide experience, 500 procedures as of October this year. To date, we've treated patients from every state in the United States and every continent except Antarctica. And we've been able to get it covered by just virtually all domestic and even some international insurers. And just to make note, we've been performing this since May, despite COVID, which exemplifies our ability to do it safely, to bring patients here in a safe manner. Obviously, they have a respiratory disorder, and through our safety protocols, we've been able to perform this. We've done about 40 cases, 50 cases since May of 2020. Next slide, please. We've published in many major journals since 2011, and several chapter publications, including a section in Up to Date, which is a clinical guideline app used by physicians. Next slide, please. Here you can see some results. We're finding after the surgery, we can get the diaphragm to strengthen. There's a rehabilitation protocol. And over time, the diaphragm moves back into its normal position, the lung opens up, and the symptoms resolve. You can see a before and after. Next slide, please. And again, another patient where, before the surgery, the diaphragm is very high. The white area on the right is the amount of lung that's aerated compared to the contralateral side, the other side. And then after the surgery, the diaphragm moves down, allowing the lung to open. Next slide, please. These are some of our patients. We've had patients come from all over the United States. We've had pediatric patients who've had unfortunate situations, and then we've had patients with spinal cord injury to try to get them off the ventilator. On the bottom left is a patient in 2011 from Australia who traveled to our center in New Jersey. Was unable to have anything done for him in his home country and had a significant recovery. Next slide, please.
Mark's life was obviously impacted significantly by this problem, as you can see by his emotional response to having some recovery. And in 2007, we pioneered phrenic nerve reconstruction for the treatment of diaphragm paralysis. And over the last 15 years, roughly, we've treated patients from all over the United States and from many countries around the globe.
It's the best thing that's ever happened in my life.
I mean, I feel a lot better now, and I can walk. I don't have any trouble hardly breathing on my job or anything like that. But I'm here just to say it is working, you know, and I'm grateful for Dr. Kaufman for doing this surgery.
That's pretty good. That's a simple test that shows you my improvement.
Very nice.
And also I'm breathing the proper way.
Yes.
I was breathing opposite when I first came here. I owe my life to Dr. Kaufman. I owe him everything. I respect him so much. I don't want to get too emotional because he means so much to me. And what he's done for me is he gave my life back.
A wise old physician once told me that it takes 25 years in medicine for anything to become standard. So we're getting there, but we still have a lot of work to do. We're publishing, we're lecturing, we're getting word out to the public. We really want to make this even more mainstream than it's already become. And that's the goal from here on in.
I'll turn it over to Dr. Elkwood now.
Hello, everyone. Thank you for joining us. Matt, thank you. I'm Andrew Elkwood, also plastic and reconstructive microsurgeon with the Center for Treatment of Paralysis. So I want to talk today, just briefly give an overview of some of the other programs that we have within the Institute and some of the disease processes that we treat. So one of the things that we take great pride in, and is one of the center points of the program, is treating brachial plexus injuries. And first question is, what is the brachial plexus? Brachial means arm, plexus means bird's nest. And essentially there are 5 nerves that come out of the neck, come out of the spinal cord, and they mix and match in an electrical junction box, if you will, in the neck and the chest, called the brachial plexus. And out of that emerges all the nerves that go to the arm and the chest. And it is a more common injury than people think. It's often a misdiagnosed injury. And patients suffer in 3 ways. The most obvious way that they suffer is they can have paralysis of their arm or chest wall, shoulder, so on. Numbness of the hand as well. And most importantly, if you were to ask these patients, the biggest issue that they get is chronic pain, sometimes pain to the point that it is intractable. And many of the patients we see state that they're actually suicidal because the pain is so severe. Next slide. So why do patients get brachial plexus injuries? Number one cause is trauma. That can be birth trauma from a traumatic delivery. Mostly what I see are motor vehicle accidents. One of the classic injuries is a patient being thrown off a motorcycle and landing on their shoulder or landing on the side of the helmet, and the head pulling away from the shoulder and tearing up those nerves. Other issues, tumor can certainly do it. Unfortunately, some of the treatment of tumors, we see it from radiation therapy, probably a little less with modern radiation techniques. They tend to protect the nerves a little bit better. Iatrogenic, unfortunately caused by the medical community, or I've seen some from chiropractic injury, training, sports. And then lastly, idiopathic. What comes to mind is something called Parsonage-Turner syndrome, which is essentially a viral swelling of the nerves. And we see that particularly in young men can get paralysis of their arms and chest. Next slide, please. So the symptoms of brachial plexus injuries, they may be subtle, they may be quite profound. It can present as loss of sensibility in the hand, or just even a funny feeling in the hand, or lack of coordination. It can be profound and just paralysis of the arm. That can go anywhere from what we call ragdoll paralysis, where the arm is just floppy, to more subtle, as we said, weaknesses, let's say within the hand itself, lack of coordination, fine motor control, grip strength, so on and so forth. And then lastly, chronic pain. As I said before, that is really the most disabling part for the patients. If you ask patients that have an arm paralysis, they'll probably tell you their most troublesome aspect is the pain. The diagnostic workup can be pretty complicated. A lot of it in our distant patients, though, can be done at their home base, so that they can come in, for the most part, well prepared for surgery, and hopefully get their initial consultation and through surgery in one trip. Part of what we do for the workup, things like chest x-ray, EMG, or nerve conduction studies, MRIs, CT myelogram. This is the one test that's fairly invasive. We usually won't order this at patient's home base until we've had an ability to examine them. X-rays, angiograms, PT evaluation. One of the things that we look for in these injuries is, are there other injuries? It often requires fairly violent trauma to cause these problems. And there are a lot of other structures in the area of the brachial plexus, bones, arteries, blood vessels, lungs, so on and so forth, all that need to be evaluated. Next slide, please. And not to get into too much detail, but there are a lot of different techniques that we use in fixing nerves. One of the analogies I'd like to use is that of the electric garage door. So I think of the musculoskeletal system a lot like the electric garage door in your house. So you have an outlet in the ceiling, which all the wiring in the ceiling we think of as the central nervous system, the brain, the spinal cord. The outlet is where the nerve emerges from the spinal cord. The nerve is obviously the wire to your electric garage door. The motor is the muscle. The chain on the garage door is the tendon. And ultimately, the garage door is the joint, the thing that you want to move. And we use these different techniques to restore function. So if you had just the wire cut, you would do a primary repair of the wire. If the wire was not conducting electricity, you would do something on that. That's what we call neuralysis, take the scar away from the nerve. If you have a chunk of wire that's frayed and not any good, you would splice in a piece of wire. We do that by borrowing nerves from the leg, just like a cardiac surgeon would take vein from the leg to replumb your heart. We take nerve from the leg to rewire your nerves. We use a technique called neurotization, which would be the equivalent of taking an extension cord and plugging your electric garage door into a different outlet. We do nerve transplants. We're one of few centers in the country that does nerve transplants, where we take nerve from someone else. So we go down to Home Depot or whatever, we buy extra wire and use that. That's essentially a nerve transplant. We do tendon-free muscle transfers, where we'll take muscle from another place and in the body, and under the microscope hook up the artery and vein. So that would be the equivalent of putting a new motor into your electric garage door. Lastly, we do things like joint fusions. That would be the equivalent of jamming the garage door open so that you can still get your car in and out of the garage. And we do that for things, again, for paralysis all the time. Next slide, please. So there are multiple steps in brachial plexus reconstruction, and this really goes for all nerve reconstruction. Step one, we recognize, diagnose the injury. We rule out other injuries. Sometimes we wait, sometimes we don't. And that's a big frustration for us, in that there's a lot of misinformation even in the professional medical community about how long to wait for these injuries. Where that miscommunication stems from is that many of these injuries will get better on their own over the course of about a year. But if you wait more than 6 months or so, anyone that you can help with surgery, you've potentially really harmed, and you can't help them with the initial type of surgery. So timing is a very big issue, and we may get into this a little bit later. The most important thing is not to have patients wait on these things until they've had an assessment, not even just by the medical community, but by a surgeon that really does this type of nerve surgery. Next step is to hook the nerves up again by whatever means we use. Then it can take 6 months or a year to see if there are results. And the results are not black and white. Sometimes there's a partial return and not others. You may be able to bend your elbow but not lift your shoulder or what have you. Then we go back to other methods like we talked about, tendon transverse joint fusions and so on. So when you see one of these complicated patients, from the day you see them, we may not finish our treatment for several years later, and there may be multiple operations. And again, it really needs to be personalized per patient. Next slide, please. As Dr. Bowers talked about before, we are very proud to be heavily published and well recognized within the field for doing this type of surgery. We're very proud of our textbook as well and numerous publications. Next slide, please. So we've been doing this type of brachial plexus surgery for over 25 years. And it is very difficult to assess in terms of success rates. In the right patients, success rates can be very high, but this is very different kind of surgery from things like removing a tumor. For the most part, if you remove the tumor, patient survives cancer-free, surgery is successful. If the tumor's still there, surgery is not successful, as long as there were no major complications. When it comes to someone that comes in with a flail arm, let's say, we define success a whole different way. For the most part, if we can get the patient out of pain, off narcotics, then we'd consider the surgery successful. We as surgeons hold ourselves to very high scrutiny. Unless we get the patient back to normal, we're never satisfied. But if you can take a patient that had a paralyzed arm and now can bend their elbow and use their hand as a helper arm, that was the success. If they can hold the meat with their arm and cut with it with their good hand, or hold the book and flip the pages with their good hand, then we consider that successful. So there's a broad spectrum of outcomes in these patients. And it really requires a multifaceted approach. It's really a multidisciplinary approach in its fullest sense. And there are multiple specialists that are involved: physical therapy, occupational therapy, just incredibly important in terms of patients' final outcomes. Next slide, please. Here's a video of, this is a patient who's 22 years old. He's trying to do the same thing with both arms. You can see he cannot lift his right arm, so that would be left side of the screen, but his right arm he can't lift. And this was after a motorcycle accident. And next slide, please. Here you can see him post-op doing push-ups. Obviously, this surgery can turn around lives. Next slide, please. Pudendal neuralgia, piriformis syndrome. This is another program within the practice and within the institute. We see many, many patients from everywhere for this. What is piriformis syndrome? Well, the sciatic nerve is the main nerve that comes out of the back and gives feeling and motion to the leg. Everyone's heard of the term sciatica. Sciatica typically is from disc disease, back disease, and so on. But in some patients, their quote unquote sciatica or back symptoms are really coming a little further down the pike and coming from an area in the pelvis where the sciatic nerve gets compressed. And it is often misdiagnosed or a component of sciatica and back disease. We see many patients that had back surgery either only partially improved or didn't improve at all, only because they have a component of piriformis syndrome. Does it mean that they were improperly diagnosed initially? No, it doesn't necessarily mean that. A lot of patients have both components. And frankly, if you were to get MRIs of most middle-aged people, they're going to have some back pathology. Back pathology is much more common than piriformis syndrome, so it often gets diagnosed first. Pudendal neuralgia is pain that patients get in their groin, in their buttock, and that's caused by compression of the pudendal nerve, which is the nerve that gives innervation to all the sexual parts and lower urologic system and so on and so forth. And just like someone would get pain or numbness in their hand from a carpal tunnel syndrome, they can get pudendal neuralgia. The problem is it's difficult to diagnose. It's difficult for patients to talk about. It's often a cause of sexual dysfunction, pain, urinary problems, bowel problems, and obviously that's hard to elicit. And unless someone does a very good history, they think that there's just some other psychological, psychosexual issue, so on and so forth. This often happens with women after childbirth. And there's a lot of other psychological aspects that can go on as a woman reaches menopause and so on and so forth. And often falsely, these people with real medical problems are written off as having some other issues. Pudendal neuralgia can be difficult to diagnose and really requires physical exam. There are a whole host of workup that we get for this. Nonetheless, we see a tremendous amount of pudendal neuralgia and piriformis syndrome. Again, these are the patients that often hang around for 10 years bouncing from physician to physician with these symptoms, and no one really makes a diagnosis. If you know how to look for these things, they could, in retrospect, they seem pretty obvious, and they are things that we can treat surgically. Next slide, please. And here you just see slide on the left, yellow is nerve, and pink is muscle, and you can see the large sciatic nerve that has a piece cut out for illustrative purposes. That's the main nerve that goes to the foot, and it comes under the piriformis muscle. And some people, either through bad luck or they have some sort of anatomic malformation, they can get compression of the nerve at that point. We go into the area of the pelvis and we release the nerve, cut a little bit of muscle, and patients often do very well. If you look at the slide on the left of the screen, that's obviously the female anatomy. In this slide, white is nerve, and you can see, if you see that label, the pudendal nerve goes through what we call Alcock's canal. It's a leathery tunnel within the pelvis. If unfortunately you get some swelling in that area, whether it be from childbirth, varicose veins, chronic constipation, bad luck, injury, riding a bike too much, you can get compression of those nerves. And surgically, we go into that area and we release those nerves. You can go to the next slide. So what are the symptoms of pudendal neuralgia? Burning, numbness, increased sensibility, sensitivity, stabbing, aching pain, abnormal temperature sensations, maybe sensations of not what we call tenesmus, not being able to empty the bowel, or urinary frequency, having urgency of urination, so on, sexual dysfunction. All of these can be signs of pudendal neuralgia. Next. Again, as we talked about before, our surgical treatment for pudendal neuralgia, surgery takes about an hour and a half or so. We go in a minimally invasive approach and release the nerves like you would a carpal tunnel in the wrist. Recovery is usually pretty quick, and patients, some patients are better in the recovery room. I would say most patients have some initial improvement, then over the course of 6 months or so get additional improvement. Surgery works very, very well for these patients. The hard part here is the diagnosis. With the right diagnosis, the success rate should be exceptionally high in pudendal neuralgia. Next slide, please. Next slide, please. Piriformis syndromes we showed before. Again, sciatic nerve comes out under the piriformis muscle. Surgically, we go in, we open up the area around the nerve. And again, some patients feel better in the recovery room. Often the patients have a two-phase recovery. They get some initial improvement, and then they continue to improve over the course of 6 months or a year or so. Next slide, please. We can go to the next slide, please. So what are the main symptoms of patients with piriformis syndrome? Very similar to back pain and sciatica. They get pain, numbness running down their leg, typically into the foot. They may get achiness of the buttocks. It's often much worse with sitting. So is pudendal neuralgia. Sometimes patients sitting in the bathroom have a relief of pain because the hole in the seat doesn't press on the nerve. So that's kind of a classic finding. About 6% of all lower back pain and sciatica is actually from piriformis syndrome. I'm finding more and more in practice that patients with failed back surgery often have piriformis syndrome, and that many patients actually have a combination of both. And we won't get into it in this talk, but there's a notion of double crush syndrome, where if a nerve is injured in one spot, it swells along the entire length of the nerve. And if it's running through a tight area and it swells in that area, it may cause impingement in multiple areas. Next slide, please. So again, our diagnosis for piriformis syndrome, most of the testing is really to see what it's not. Physical exam is the most important aspect of evaluating it. We also use trigger blocks where we'll inject local anesthetic into those areas. And if the patient gets a temporary relief for an hour or two, or however long the anesthetic that we use lasts, you know that's, like we say, that's where the money is. That's probably where the problem lies. Next. So there are some non-surgical treatments of piriformis syndrome and pudendal neuralgia. Physical therapy sometimes can be helpful, in anti-inflammatory medications. Sometimes we will give Botox into the muscles and to decrease the spasm and compression on the nerves. Steroids injection into the area in the nerves can sometimes be helpful. But the truth is, most patients that either have long-standing disease or very severe disease wind up with surgery. And many of those patients do exceptionally well. For the most part, the patients that can do well with non-surgical options are the ones that have either short-term disease or minor cases. Next slide, please. So, the Center for Paralysis and Reconstructive Nerve Surgery, CRPNS. We are really devoted to innovative surgical treatments, as you can see. What we have listed here, what we've shown you here is just a small percentage of the types of surgeries that we do. We tend to center around peripheral nerve disorders, but not exclusively so. We take care of spinal cord injury and stroke. We don't have a cure yet for spinal injury or stroke. Mankind does not have that, hopefully soon, but there's a lot of surgeries that we can do to actually help patients and help their function. We're very proud of our international program. We feel that our facilities and our team is second to none. And I think a lot of our results and a lot of patients that have improved significantly speak well to that. Next slide, please. We have many clinical research projects going on right now, and these are just some of them. Pressure ulcers in patients with spinal cord injury, reinnervating their buttocks so they can feel their buttocks again. The surgery that we do for paraplegics, stroke, athletic pubalgia, diaphragm paralysis, Graves' ophthalmopathy, lymphedema, erectile dysfunction in patients, for the most part, patients that have had prostate cancer treatment and surgery, post-mastectomy pain syndrome, foot drop, radiation plexopathy, compensatory hyperhidrosis. We do have our outreach nurse, Ellen McHugh. So if you feel that any of these patients may fall into one of these categories for clinical research, please reach out to Ellen McHugh. We have contact information for our group, as well as patients that are not part of a research protocol that just require care. We're happy to get back to anyone. We have an entire team that investigates internet inquiries and distant inquiries to the Institute, and we'll get back to them very promptly as to whether or not they may be a candidate. If they may be a candidate, our staff will start collecting data, present it to the physicians, and most of these patients will get a personal call from the physicians to see if they truly are candidates. Next slide, please. We thank you very much. We have a few minutes to open up for questions. I will turn it back over to Dr. Bauer to moderate our question session. Thank you very much.
So, Dr. Oakwood and Dr. Kaufman, thank you so much. And again, it is a an honor and a privilege to work with you both on these complex cases. And as Dr. Kaufman's video pointed out from the patient perspective, the impact that we get to have in these patients is beyond belief, in the sense that these patients have been told from wherever they're living by many individuals that there is no option for them, and when they investigate, find the center, and get in to meet Dr. Kaufman or Elkwood, the surprise on their face, and to see these people on a weekly basis that I get to participate with both of you, is just phenomenal to see the hope that's in their eyes and the joy that's there when they leave, having had some corrective surgery. So with just a couple minutes left, I find it fascinating, and this will go to Matt and then to Andrew. You know, we were all told growing up that diaphragmatic paralysis, or the entities that Dr. Elkwood mentioned, were not treatable and were insignificant. So, Dr. Kaufman, what led you to believe so many years ago that it was significant for diaphragmatic paralysis, and how you chose to embark on a methodology to correct that for our patients?
Yeah, Tom. So the practice for years, with the foresight of Dr. Elkwood in developing the framework of the practice, looking at using the philosophies of innovation and super specialty, and tackling some of these complex problems, particularly in the peripheral nerve injury realm. So Dr. Elkwood had been doing brachial plexus for several years, and the impact of our internet presence had brought in patients with various types of peripheral nerve injuries, and early on seeing some patients that had come through with diaphragm paralysis, and starting to recognize this as an entity that wasn't something that you could just learn to live with based upon this sincerity of their concerns, and the loss of their quality of life, and looking at, you know, taking a problem-oriented approach to these various issues, and saying, hey, this is a muscle that's innervated by a nerve. There's likely a nerve injury to this problem, and perhaps it's something we can use standard nerve reconstruction methods to tackle. And that was kind of the framework. And sometimes it's a matter of doing cadaver dissections, and sometimes it's a matter of, you know, referencing translational research from animal data, and then starting to do it in a trial basis. And so it's slowly morphed into a clinical treatment that, you know, that became mainstream, and seeing that it was effective and that we could better characterize the injury. One of the issues with phrenic nerve reconstruction and diaphragm paralysis is there's no imaging modality that's going to identify phrenic nerve injury. There's no MRI or CAT scan, so it's hard for most clinicians to identify the injury and where it is and what's going on. And only having the experience of doing the surgery can you sometimes appreciate the pathology. And so, you know, I think we've done that for diaphragm paralysis and for many other peripheral nerve disorders. And obviously it's been very successful that way.
Dr. Elkwood, I've over the last 30 years had the fortune of watching and operating with many people, but I've never met anybody with your knowledge of the brachial plexus that, as I look back on, I thought was incredibly complicated. So how did you develop such a significant expertise in an area that so many people find so complicated?
Well, first of all, thank you for that, Tom. I enjoy the challenge of it. Most people don't really understand reconstructive surgery, what that really amounts to. You know, we think that a well-trained reconstructive surgeon takes all their training time and is really putting tools into their toolbox. And every operation, every technique that you learn is another tool that's in your toolbox. And when you show up to the job with a patient, let's say that's injured, you open up that toolbox, and the more procedures that you know, the better you know anatomy, you can apply different different tools from your box to best help the patient. As I mentioned before, one of the things that I personally find them so satisfying with reconstructive surgery is that there's no real endpoint. It's not black and white. It's a wonderful thing, obviously, to save lives and resect tumors and so on and so forth, but it's a different endpoint. For us, it can be sometimes frustrating, but very challenging, that the only endpoint is normalcy. And the more you learn, the more of these tools you have, the more techniques you have, the more you better understand anatomy, the more you can help these patients. So it's wonderful to get a patient with a paralyzed arm out of pain. It's especially wonderful to get them to bend their elbow, let's say, but it's even more wonderful if you can get them to write again, or they can go back to playing the piano, or they can feed themselves, put their makeup on, comb their hair, or whatever. So there's no one absolute endpoint. So I think what drives this is getting closer and closer to perfection, which we'll obviously never achieve. But every time you do a surgery, you're thinking more about more nuances. You're thinking about what's in front of you. You're problem solving, and you're applying that to the next patient that you see. So,
thank you both. Deanna had a question for both of you, and it's centered around the use of physical therapy. So, in our remaining minute, Dr. Kaufman, could you comment on the role of the physical therapist in what you do? We alluded to it, but didn't spend a lot of time. So just a short answer on that. And then to Dr. Elkwood, after that, the question is going to be related to the use of splints as an adjunct or instead of surgery in some of your brachial plexus work. But Dr. Kaufman.
For the real rehabilitation phase of the patients who have undergone phrenic nerve reconstruction, it's a very specific and organized and structured form of physical therapy that we feel is absolutely integral to their recovery. Just like rehabilitating any other muscle, it needs to be first innervated or have an impulse into it, and then strengthened. And the strengthening portion is critical, and it involves physical therapy, specifically diaphragm physical therapy, to strengthen that particular muscle using specific breathing techniques and implementing them during cardiovascular exercise. And we advocate for physical therapy for at least 2 or 3 months each year during the recovery, feeling that that's optimal, given that the recovery process and the strengthening of the diaphragm really goes on for 2 to 2.5 years or even longer. And so the physical therapy component is almost equally critical to the surgery itself. Absolutely essential.
Dr. Elkwood, the role of splints to complement or instead of what you do?
Well, we use splints for many different purposes. Splints we use sometimes temporarily to protect a repair or protect an injury. We use a splint sometimes to straighten out joints, over time serial splinting. And it's very, very helpful. I do think long-term splints can usually be supplanted better with surgery. So just a quick, for instance, in a patient that can't move their thumb, if their thumb is stuck in this position, you can't pinch against it. We'll often oppose the thumb this way so that if a patient can pinch against the thumb, even if they can't move it. You can do that with a splint, but splint is not necessarily a good long-term goal there. Surgery to fuse the joint in position is much better. So splints are very, very helpful. We couldn't do a lot of the work we do without them, but again, they, just like anything else, they need to be used judiciously.
Well, I want to thank all of our attendees from around the world. I want to thank our sponsors and our organizers for putting this together for us. I want to thank Hackensack Meridian Health for their support through Compelling Health. I think this is an excellent partnership, taking an incredibly progressive system and partnering with a incredibly progressive practice to form this center. It's amazing to be part of it for the recent years. It's providing hope to our patients in an exceedingly compassionate care that's focused on quality, a rigorous academic approach to ensure that we're continuing to grow and offer better and better solutions. And all of this is done under the supervision of our review board in a research mechanism to ensure the highest quality. So I thank you all for attending, for your partnership in this excellent effort. And if you have any questions, you can visit our site at compellinghope.com or email us at globalhealth@hmhn.org, or you can reach out to Drs. Elkwood and Kaufman. I thank you and hope you have a wonderful day. Thank you.
Thank you, everyone. Stay safe.
Thank you.
Thank you.